What factors should be considered when administering naloxone to a patient suspected of opioid overdose, and what other potential complications or limitations associated with naloxone use? Answer: naloxone, an opioid antagonist, is the first-line treatment for opioid overdose, especially in cases of respiratory depression. The primary considerations when administering naloxone include patient's opioid history. Naloxone is highly effective for opioid overdoses, but may be less effective for overdoses involving mixed drug intoxications, e.g., opioids and benzodiazepines. Initial dosing and titration. Start with an initial dose of 0.4 to 2 ng of IM subcutaneously. If the desired clinical response, restoration of adequate respiration, is not achieved after 2-3 minutes, further doses may be administered at 2-3 minute intervals. Complications. The potential complication of naloxone is precipitating opioid withdrawal in dependent individuals, which can lead to symptoms such as agitation, tachycardia, nausea, and vomiting. Duration of action. Naloxone has a shorter half-life than many opioids, so repeat dosing may be necessary, especially for long-acting opioids like methadone. Relevant guidelines: the American Heart Association, AHA, and Emergency Nurses Association, ENA. A 55-year-old male presents to the emergency department with confusion, hypotension, and a fever of 102 degrees. His heart rate is 110 bpm and respiratory rate is 22 breaths per minute. What is the most appropriate next step in his management? Answer: the patient's presentation is suggestive of sepsis, a life-threatening condition due to infection where there is widespread inflammation and potential organ dysfunction. Early recognition is critical for survival. The Sepsis 3 criteria recommend using the Q-SOFA Quick Sequential Organ Failure Assessment score for early screening. The Q-SOFA includes systolic blood pressure 22 breaths, Glasgow Coma Scale GCS 15, given that this patient has hypotension, RP 100 mHg, tachypnea, respiratory rate 22, and altered mental status, confusion, meets 2-3 of the Q-SOFA criteria, suggesting he is at high risk for severe sepsis or septic shock. Immediate intervention should include early antibiotics, administer broad-spectrum antibiotics within 1 hour of sepsis recognition, fluid resuscitation, IV fluids, normal saline or Ringer's lactate to restore perfusion, lactate measurement, measure serum lactate to assess tissue perfusion and guide further resuscitation efforts. Mr. Roberts is brought to the emergency department after accidental exposure to a pesticide containing organophosphates. He is experiencing excessive salivation, meiosis, and difficulty breathing. What is the immediate treatment protocol for organophosphate poisoning? Answer: organophosphate poisoning occurs due to the inhibition of acetylcholinesterase, leading to an accumulation of acetylcholine and overstimulation of the muscarinic and nicotinic receptors. Symptoms include SLUDGE, salivation, lacrimation, urination, defecation, gastrointestinal distress, and emesis, meiosis, pinpoint pupils, and bradycardia or hypotension due to parasympathetic overstimulation. The treatment protocol involves atropine, a muscarinic antagonist that blocks the effects of acetylcholine, typically administered in high doses, e.g. 1-2 mg IV, repeated every 3-5 minutes until symptoms resolve. Pralidoxime, 2-PAM, reactivates acetylcholinesterase and should be given as soon as possible to reverse the effects of the organophosphate, typically administered at a dose of 1-2 grams IV. Supportive care. Ensure adequate airway management, oxygenation, and ventilation, especially if the patient has respiratory distress or failure. Relevant guidelines. According to the American College of Emergency Physicians, ACEP, and National Capital Poison Center, organophosphate poisoning should be treated aggressively with atropine and pralidoxime. What are the indications and limitations of activated charcoal in the treatment of toxic ingestions, and within what time frame should it be administered for maximum efficacy? Answer: activated charcoal is commonly used to prevent further absorption of ingested toxins, especially for poisons or drugs that are absorbed in the gastrointestinal tract. The general indications for activated charcoal include recent ingestion of potentially toxic substances. Activated charcoal is most effective when administered within 1 hour of ingestion of substances that are absorbed by charcoal, such as acetaminophen, aspirin, or certain pesticides. Multiple dose activated charcoal may be used for sustained release drugs or those that undergo enterohepatic circulation, such as theophylline or phenobarbital. Limitations: activated charcoal is not effective for corrosive substances, e.g. strong acids, alkalis, alcohols, e.g. ethanol, methanol, lithium, and iron poisoning. Contraindications include unprotected airway, risk of aspiration, patients with altered mental status, due to risk of aspiration unless the airway is secured. What is the role of antibiotic stewardship in the management of sepsis, and how does it influence the outcome for patients with suspected infections? Answer: antibiotic stewardship is a strategy aimed at promoting the appropriate use of antibiotics, ensuring that patients receive the right antibiotic at the right dose, time, and duration. In sepsis management, appropriate antibiotic therapy is crucial, as empiric therapy is often initiated before the specific pathogen is identified. Key components of antibiotic stewardship include rapid initiation of therapy, administering broad-spectrum antibiotics within 1 hour of recognizing sepsis to cover likely pathogens, narrowing the antibiotic spectrum. Once culture results are available, de-escalate to targeted therapy to avoid unnecessary use of broad-spectrum antibiotics and reduce the risk of antimicrobial resistance. Monitoring for efficacy. Regularly assess the patient's response to therapy and adjust based on clinical progress and culture sensitivity results. Impact on outcome. Studies have shown that appropriate and timely use of antibiotics can significantly improve survival rates, while inappropriate or delayed antibiotic therapy is associated with higher mortality and complications. When is it appropriate to administer flumazenil for a benzodiazepine overdose, and what are the risks associated with its use? Answer: flumazenil is a benzodiazepine receptor antagonist that can reverse the sedative effects of benzodiazepines. However, its use in overdose situations should be approached with caution. It may be appropriate in cases of isolated benzodiazepine overdose with respiratory depression or coma when no other central nervous system depressants are involved. Risks and considerations. Seizures. Flumazenil can precipitate seizures, particularly in patients who have chronic benzodiazepine use or have co-ingested other proconvulsant drugs. Overdose of mixed drugs. Flumazenil should not be used in cases of suspected polydrug overdose, especially with substances like tricyclic antidepressants, where it may worsen the clinical scenario. Reversal of withdrawal symptoms. In patients with dependence, flumazenil may precipitate acute withdrawal symptoms, including agitation and seizures. What is the rationale behind administering broad-spectrum antibiotics within 1 hour of recognizing septic shock, and how does this timing influence patient outcomes? Answer: early and appropriate antibiotic administration is a cornerstone of septic shock management, as rapid initiation improves outcomes by addressing the underlying infection quickly. The rationale behind the 1 hour window is as follows. Time-sensitive therapy. Every hour of delayed antibiotic administration increases the risk of mortality by approximately 7.10%, making rapid treatment critical. Broad-spectrum therapy. Initially, broad-spectrum antibiotics are used to cover a wide range of potential pathogens until the specific pathogen is identified. Reduced organ failure. Early antibiotic therapy helps prevent further progression of organ dysfunction due to the systemic inflammatory response in sepsis. Relevant guidelines. The Surviving Sepsis Campaign advocates for the administration of broad-spectrum antibiotics within the first hour of septic shock recognition in combination with adequate fluid resuscitation. Under what circumstances is whole bowel irrigation indicated in the management of toxic ingestions, and what are the risks associated with this procedure? Answer: whole bowel irrigation is used in cases of sustained release or enteric-coated medications where the drug may not be fully absorbed by activated charcoal. WBI is typically performed with polyethylene glycol PEG solution, and indications include ingestion of sustained release formulations or substances that may cause delayed toxicity, foreign bodies, e.g. drug packets or metallic objects that might pose a risk if they remain in the gastrointestinal tract. Risks: electrolyte imbalance. Large volumes of PEG solution can lead to shifts in electrolytes and dehydration. Aspiration risk. Care should be taken to prevent aspiration, especially in patients with compromised airways. Relevant guidelines. The American Academy of Clinical Toxicology recommends WBI for specific toxic ingestions alongside monitoring for potential complications. Mrs. Green, the 32-year-old woman with a history of depression, is brought to the emergency department after being found unresponsive. She was found with empty bottles of acetaminophen and benzo pills at the scene. What should the emergency nurse prioritize in her management? Answer: in this multi-drug overdose scenario, the emergency nurse must prioritize airway management, secure the airway, provide supplemental oxygen, and prepare for possible intubation if the patient is unable to maintain her airway. Assessment of toxicity. Acetaminophen overdose. Check serum acetaminophen levels immediately and start N-acetylcysteine if within the toxic range to prevent liver damage. Benzodiazepine overdose. Flumazenil may be used cautiously if there is isolated benzodiazepine overdose, but this should not be used if other central nervous system depressants, e.g. alcohol, are suspected. Decontamination. Activated charcoal can be considered if the ingestion occurred within 1 hour of presentation and is appropriate for the substances ingested. Relevant guidelines. Toxicology guidelines support N-acetylcysteine for acetaminophen overdose and highlight careful management of mixed overdoses due to the risks associated with reversing benzodiazepines. What is the treatment protocol for a patient with suspected methanol poisoning, and why is fomepizole preferred over ethanol in some cases? Answer: methanol poisoning results from the metabolism of methanol to formaldehyde and formic acid, which are highly toxic to the central nervous system and optic nerve. The treatment protocol includes fomepizole or ethanol. Both inhibit the enzyme alcohol dehydrogenase, preventing the conversion of methanol to its toxic metabolites. Fomepizole is generally preferred due to more predictable pharmacokinetics and fewer side effects compared to ethanol. No need for frequent monitoring of blood alcohol levels. Hemodialysis. In severe poisoning, especially with high methanol levels or associated metabolic acidosis, hemodialysis is indicated to rapidly clear methanol and its metabolites from the bloodstream. Relevant guidelines. The American College of Emergency Physicians recommends fomepizole as the first-line treatment for methanol poisoning due to its effectiveness and safety profile. What is the recommended management strategy for a patient diagnosed with severe preeclampsia, and how does it differ from the management of eclampsia? Answer: severe preeclampsia is characterized by elevated blood pressure, BP 106 to 100 Hg, proteinuria, and signs of end organ damage. The management focuses on controlling BP and preventing eclampsia seizures. Common interventions include libitalol or hydrolazine for BP control, magnesium sulfate to prevent seizures, corticosteroids e.g. betamethasone to promote fetal lung maturity if delivery is imminent, monitoring of renal function, liver enzymes, and fetal status via non-stress tests or ultrasound. In contrast, eclampsia, which involves seizures, requires magnesium sulfate for seizure control and immediate delivery once the patient is stabilized, as it is the definitive treatment for both conditions. What are the primary considerations when managing a patient with heat stroke, and how can you differentiate it from heat exhaustion? Answer: heat stroke is a medical emergency characterized by a core body temperature 104 Fahrenheit alter mental status e.g. confusion, agitation, delirium, and signs of organ dysfunction. In contrast, heat exhaustion presents with profuse sweating, weakness, dizziness, and nausea, but without the severe temperature elevation or alter mental status seen in heat stroke. Management of heat stroke involves immediate cooling through methods such as evaporative cooling, spraying the patient with water, and using fans. Ice water immersion, if feasible, ice packs to areas with large blood vessels, neck, groin, armpits, IV fluid resuscitation, normal saline or Ringer's lactate, monitoring for complications like rhabdomyolysis and disseminated intravascular coagulation, which may occur due to muscle breakdown and the hypercoagulable state. Guidelines from the American Heart Association has stressed the importance of rapidly lowering core temperature, as this can prevent multi-organ failure and death. Mr. Harrison, a 36-week pregnant woman with a history of severe preeclampsia, presents with sudden onset of severe abdominal pain and vaginal bleeding. On ultrasound, placental abruption is diagnosed. What is the first-line management approach for Mr. Harrison's condition? Answer: in the case of placental abruption, where the placenta prematurely separates from the uterine wall, the management depends on the severity of the condition and the gestational age. If the bleeding is significant and the fetus is in distress or dead, an immediate cesarean section is typically indicated. If the bleeding is minor and the fetus is stable, expectant management may be considered, but close monitoring is crucial. The first-line management includes monitoring maternal hemodynamic stability, including BP and lab work for coagulation abnormalities, fetal monitoring to assess fetal distress, non-stress tests or biophysical profile, IV fluid resuscitation and blood transfusions if necessary, administration of magnesium sulfate for fetal neuroprotection, especially if the patient is near term. Guidelines from ACOG emphasize the need for rapid delivery in cases of significant placental abruption with fetal distress. What is the primary goal when managing a patient with hypothermia, and how does the approach change depending on the severity of the hypothermia? Answer: the primary goal in managing hypothermia is to prevent further heat loss, warm the patient to a normal temperature, and prevent complications like arrhythmias or organ failure. Hypothermia is classified into 3 stages: mild hypothermia 3-2, 3-5 digs 89.6, 9-5 dig. The patient may shiver and be alert. Management involves passive rewarming e.g. covering with blankets, warm fluids orally, Moderate hypothermia 2832 deg Ceti 2.4 89.6 deg. The patient may stop shivering and show confusion or slurred speech. Active external warming G. Warme, heating pads and IV fluids should be administered. Severe hypothermia 28 deg Ceti 2.4 deg. The patient may lose consciousness and have bradycardic arrhythmia. Active internal warming G. Warm IV fluids, warm oxygen or lavage and cardiac monitoring are required. The American Heart Association resuscitation guidelines emphasize that rewarming should be gradual to avoid complications like rewarming shock, particularly in severe cases. How does the management of an ectopic pregnancy differ depending on whether the pregnancy is ruptured or unruptured? Answer: management of ectopic pregnancy depends on whether the pregnancy is ruptured or unruptured. Unruptured ectopic pregnancy. Methotrexate therapy is the preferred treatment if the patient is hemodynamically stable and the ectopic mass is small, usually 3.5 centimeters, without signs of fetal cardiac activity. Methotrexate inhibits folate synthesis and prevents further trophoblastic cell division, allowing the ectopic pregnancy to resolve over time. Follow-up is essential to monitor for decline in HCG levels. Ruptured ectopic pregnancy. This is a medical emergency requiring surgical intervention, laparoscopy, or laparotomy to control bleeding and remove the ectopic pregnancy. In cases where the tube is not salvageable, salpingectomy, removal of the affected fallopian tube, may be required. What is the initial approach to managing a patient with snakebite envenomation, and why is antivenom administration critical in certain cases? Answer: the initial management of snakebite envenomation focuses on the following steps: ensure patient safety and avoid further snake bites, e.g., by immobilizing the affected limb. Assessment of the type of snake, if possible, and clinical symptoms, e.g., swelling, pain, discoloration, or systemic signs such as hypotension, IV fluid resuscitation to manage shock and maintain perfusion. Antivenom administration is indicated for patients with severe symptoms, e.g., significant swelling, systemic effects such as coagulopathy or respiratory distress. The American Society of Toxicology and National Poison Control Centers recommend specific antivenoms for different species based on local availability and protocols. Antivenom is critical in preventing or reversing systemic complications such as hemolysis, coagulopathy, and neurotoxic effects. Without timely antivenom, these complications can lead to multi-organ failure or death. How should you differentiate between heat exhaustion and heat stroke in an emergency setting, and what are the key management steps for heat stroke? Answer: heat exhaustion and heat stroke both result from prolonged exposure to high temperatures but differ in severity. Heat exhaustion is a milder form and is characterized by excessive sweating and weakness, nausea, dizziness, and fainting, a normal or slightly elevated body temperature 104 deg Fahrtidec, alter mental status, e.g., confusion, agitation, delirium, absence of sweating in classic cases as the body's cooling mechanism is overwhelmed. Management of heat stroke includes rapid cooling, ice water immersion, cooling blankets, fans, IV hydration with saline or Ringer's lactate, monitoring for complications like rhabdomyolysis or disseminated intravascular coagulation, DIC, and ensuring continuous cardiac and respiratory monitoring. In the case of a 28-week pregnant woman with vaginal bleeding and suspected placental previa, what are the key considerations for management? Answer: in placenta previa, the placenta is abnormally positioned over the cervical os, which can cause significant bleeding, especially in the later stages of pregnancy. Key considerations include avoid vaginal exams, as this may cause further bleeding. Ultrasound is the gold standard for diagnosis. Hospitalization for close monitoring of maternal and fetal status is often required. If bleeding is severe or the fetus is compromised, an emergency cesarean section may be indicated. Steroid therapy may be given if delivery is imminent to promote fetal lung maturity. The guidelines from ACOG recommend avoiding labor induction and opting for cesarean delivery once the fetus reaches 3-4-3-6 weeks or earlier if maternal or fetal well-being is at risk. What are the critical steps in managing a patient presenting with anaphylaxis from a wasp sting, and why is immediate epinephrine administration vital? Answer: in anaphylaxis, the body reacts to an allergen such as a wasp sting by releasing large amounts of histamine, leading to airway swelling, hypotension, and shock. The critical steps include immediate administration of epinephrine 0.3–0.5 mg intramuscularly in adults, which counteracts histamine and restores vascular tone. oxygen administration to address potential airway compromise. Antihistamines and corticosteroids may be used to alleviate symptoms, but epinephrine remains the first-line treatment. Immediate administration of epinephrine is crucial because it acts within minutes to reverse the life-threatening effects of anaphylaxis, preventing respiratory failure and shock. Guidelines from AAAAI stress that delaying epinephrine can result in fatal consequences. A 45-year-old male patient presents with severe, localized right lower quadrant abdominal pain, nausea, and fever. The patient appears ill and is in moderate distress. The patient's white blood cell count is elevated. What is the most likely diagnosis, and how would you manage this patient in the emergency department? What diagnostic tests should be prioritized, and what is the role of imaging in this case? Answer: the most likely diagnosis is acute appendicitis based on the patient's symptoms of localized abdominal pain, fever, nausea, and elevated white blood cell count. The management of this patient should include initial stabilization, IV access for fluid resuscitation, pain control, e.g. opioid or NSAIDs, and antibiotics to cover both gram-negative and anaerobic bacteria, e.g. ceftriaxone plus metronidazole. Diagnostic imaging. A CT scan of the abdomen is considered the gold standard for diagnosing appendicitis. If CT is not available, or if the patient is pregnant, an ultrasound can be used as an alternative to identify an inflamed appendix. Surgical consultation. Early consultation with a surgeon is essential, as most patients with acute appendicitis require an appendectomy. If perforation is suspected, the management may include drainage and a prolonged course of antibiotics. Guidelines for acute appendicitis management suggest early intervention to prevent complications like perforation. According to the American College of Surgeons Acts, appendicitis should be managed within 24 hours of presentation to minimize morbidity. A 68-year-old female with a history of hypertension and type 2 diabetes presents to the emergency department with fatigue, decreased urine output, and swelling in her legs. Her laboratory results show a serum creatinine of 3.2 mdl, baseline 1 mdl, BUN of 35 mdl, and a urine output of 12 hr. What is the most likely cause of her acute kidney injury, AKI, and what initial interventions should be taken to manage her condition? Answer: the most likely cause of this patient's acute kidney injury, AKI, is prerenal due to hypoperfusion, as suggested by her clinical presentation of fatigue, decreased urine output, and the elevation of creatinine and BUN. Her history of hypertension and diabetes places her at high risk for prerenal AKI from decreased renal perfusion. Initial management: fluid resuscitation. Administer IV fluids, normal saline or lactated ringers, to correct any volume depletion and restore renal perfusion. Monitoring: close monitoring of urine output, blood pressure, and electrolytes is essential. Discontinue nephrotoxic medications. Review medications, GAC inhibitors, NSAIDs, that could worsen renal perfusion. Further testing, urine sodium and fractional excretion of sodium, FeNO, can help differentiate prerenal AKI from intrinsic causes. If prerenal causes are excluded and the patient does not respond to fluids, further workup for intrinsic renal causes, e.g. glomerulonephritis, acute tubular necrosis, may be necessary. A 54-year-old male with chronic kidney disease presents with weakness, palpitations, and numbness in his lower extremities. His ECG shows peaked T waves, and his potassium level is 7.1 mmol. What are the immediate steps to treat this patient, and how does the treatment work to address hyperkalemia? Answer: this patient is presenting with severe hyperkalemia, potassium level of 7.1 mmol, which is a life-threatening emergency. The CG changes of peaked T waves indicate significant potassium disturbance. Immediate management includes stabilizing the myocardium. Calcium gluconate 1 euro, 2 euro ml of 10% Soluin Romano be administered to protect the heart and reverse the ECG changes. This does not lower potassium but stabilizes the myocardial cell membrane to prevent arrhythmias. Shifting potassium intracellularly. Insulin and glucose. 10 units of regular insulin with 2550 grams of glucose help to shift potassium from the bloodstream into the cells. This is the most immediate and effective treatment. Promoting potassium excretion, diuretics, e.g. furosemide, may be used if the patient has adequate kidney function, or sodium bicarbonate can be administered to induce alkalosis, which also shifts potassium intracellularly. Dialysis. If the hyperkalemia persists or worsens despite medical therapy, hemodialysis may be required to remove potassium directly from the body. Guideline: the National Kidney Foundation in Kiev and American Heart Association recommend prompt correction of hyperkalemia to prevent life-threatening arrhythmias. A 60-year-old male with a history of cirrhosis and alcohol use disorder presents to the emergency department with vomiting blood and black tarry stools. He is hypertensive with a blood pressure of 85/60 mmHg and his heart rate is elevated. What are the initial steps in managing this patient, and what are the specific considerations when managing variceal bleeding in patients with cirrhosis? Answer: this patient is presenting with upper gastrointestinal (GI) bleeding, likely from esophageal varices, as suggested by his history of cirrhosis and alcohol use disorder. Initial management should focus on stabilization and controlling the bleeding. Initial stabilization. IV access. Establish large bore IV access, preferably 2 lines, for fluid resuscitation with crystalloids (G) normal saline to stabilize blood pressure. Blood products. Administer packed red blood (ECS) and fresh frozen plasma (FFP) is indicated to correct anemia and coagulopathy. Management of variceal bleeding. Vasoconstrictors. Octreotide somatostatin analog should be initiated to reduce portal venous pressure and control bleeding from varices. Endoscopy. An urgent upper GI endoscopy is needed to confirm the diagnosis and provide therapeutic interventions such as band ligation or sclerotherapy, antibiotics, prophylactic antibiotics (G) ciprofloxacin or ceftriaxone should be given to prevent bacterial infections, which are common in cirrhotic patients with GI bleeding. MS. Parker, a 72-year-old female with a history of chronic heart failure and renal impairment, presents to the emergency department with confusion and generalized weakness. Her laboratory results show a serum sodium of 120 ml. What is the most likely cause of her hyponatremia, and how should this condition be managed in the emergency department? Answer: MS. Parker's hyponatremia is likely due to hypovolemic hyponatremia, often seen in patients with heart failure and renal dysfunction. This occurs due to water retention in the setting of poor renal perfusion, leading to dilutional hyponatremia. Initial management. Fluid restriction. The first line of treatment for hypovolemic hyponatremia is fluid restriction, particularly in elderly patients with heart failure. The goal is to reduce total body water and improve sodium levels without worsening heart failure symptoms. Hypertonic saline. If the patient is symptomatic e.g. confusion, weakness, 3% saline may be administered in a controlled fashion to raise the sodium level gradually, typically at a rate of no more than 6 ml per 24 hours to avoid osmotic demyelination syndrome. Further workup. Check the patient's serum osmolality and urine sodium levels to confirm the diagnosis and help differentiate between different causes of hyponatremia e.g. heart failure, cirrhosis nephrotic syndrome. A 35-year-old male presents with hematmesis and melena. His vital signs show tachycardia, hypotension, and he appears pale. What are the first-line treatments to stabilize the patient, and what are the key diagnostic tools to identify the source of bleeding? Answer: in this patient with upper GI bleeding, the first priority is to stabilize and identify the bleeding source. Initial management. Resuscitation. Establish IV access. Administer crystalloid fluids to restore circulating volume and monitor vital signs closely. Blood products (ECS) should be given as necessary to maintain hemoglobin levels above 7-8 grams still. Diagnostic workup. Endoscopy. Upper GI endoscopy is the gold standard for identifying and treating sources of bleeding e.g. ulcers, varices, nasogastric 2, NGT aspiration can be used initially to determine if the bleeding is coming from the upper GI tract e.g. bright red blood versus coffee ground material. Guideline. According to the American College of Gastroenterology, initial management includes volume resuscitation and early endoscopy for both diagnostic and therapeutic intervention e.g. band ligation for varices or hemostasis for ulcers. A 40-year-old male with a history of dehydration presents with decreased urine output, confusion, and elevated creatinine levels. How do you differentiate between prerenal, intrinsic, and postrenal causes of AKI in this patient, and what steps would you take to treat him based on the likely etiology? Answer: to differentiate between prerenal, intrinsic, and postrenal causes of AKI, the following steps should be taken. Prerenal likely cause: dehydration, which reduces renal perfusion. Urine sodium is typically low, 20 mecq. The fractional excretion of sodium phenate is usually 40 mecq. Phenate 2%. Treatment: supportive care and consider dialysis if severe. Postrenal likely cause: obstruction e.g. kidney stones, enlarged prostate. Diagnose with ultrasound of the kidneys to identify hydronephrosis. Treatment: decompression of the urinary tract e.g. catheterization stent. A 78-year-old male with chronic kidney disease presents with nausea, vomiting, and confusion. His laboratory results show a calcium level of 14.2 dl and a serum creatinine of 4.5 mdl. What is the most likely cause of his hypocalcemia, and what treatment strategies would you recommend? Answer: the most likely cause of hypocalcemia in this patient is secondary hyperparathyroidism related to his chronic kidney disease (CKD). In CKD, impaired phosphate excretion leads to low calcium levels, which then stimulate increased parathyroid hormone (PH) production, leading to calcium mobilization from the bones. Initial treatment: hydration, aggressive IV hydration with normal saline to promote renal calcium excretion, calcitonin and bisphosphonates (e.g. zoldronic acid) can be used to decrease bone resorption. Further management: consider dialysis for refractory hypercalcemia, especially in patients with CKD who are unable to excrete calcium efficiently. Guideline: according to kidney disease, improving global outcomes, KDIGO managing secondary hyperparathyroidism in CKD includes optimizing phosphate control and using agents like calcimimetics and vitamin D analogs. A 55-year-old male with a history of liver cirrhosis and esophageal varices presents with active vomiting of blood. His vital signs are unstable and he is showing signs of hypovolemic shock. What is the immediate management, and what is the role of endoscopy in managing variceal bleeding? Answer: in a patient with esophageal variceal bleeding, the immediate management steps should focus on stabilization. IV fluids and blood prods to ECS or EFP should be given to stabilize the patient's circulatory volume. Vasoconstrictors e.g. opioids should be started to reduce portal pressure and control bleeding. Endoscopy: urgent endoscopy is critical for confirming the diagnosis and treating the varices via band ligation or sclerotherapy. Guideline: according to AASLD guidelines, early use of opioid and endoscopy is recommended to control variceal bleeding and prevent rebleeding. 45-year-old male with diabetes presents with confusion and muscle cramps. His laboratory results show serum potassium level of 2.5 mmol. What is the most likely cause of his hypokalemia, and how should this condition be managed? Answer: the most likely cause of hypokalemia in this patient is diuretic use, which can lead to excessive potassium loss in the urine. Management: potassium replacement. Start with oral potassium if the patient is stable, or IV potassium chloride if the patient is symptomatic or has ECG changes. Electrolyte monitoring: recheck potassium levels frequently after replacement. Underlying cause: review medications, especially thiazide or loop diuretics, which can cause potassium depletion. Consider aldosterone antagonists e.g. spironolactone in cases where diuretics are essential for managing conditions like heart failure. Guideline: according to nephrology and hypertension guidelines, potassium should be corrected gradually to avoid complications like arrhythmias. A 32-year-old patient with known sickle cell disease presents to the emergency department with a sudden onset left-sided weakness and slurred speech. Imaging reveals an ischemic stroke. What is the recommended approach to management in this patient, considering their underlying sickle cell disease, and what interventions may reduce the risk of future strokes? Answer: the patient's presentation of sudden onset neurological deficits, such as left-sided weakness and slurred speech, is concerning for an ischemic stroke. In patients with sickle cell disease (SCD), strokes can occur due to vaso-occlusion and reduced cerebral blood flow, often related to sickled red blood cells. The immediate management of stroke in a patient with sickle cell disease includes urgent neuroimaging (ET or MRI) to confirm the diagnosis of an ischemic stroke and rule out hemorrhagic stroke, hydration, intravenous fluids to reduce blood viscosity and improve perfusion, oxygen therapy to maintain adequate oxygen levels and reduce sickling of red blood cells, pain management to reduce stress, which can worsen sickling and exacerbate the crisis, blood transfusion. Blood transfusions are a key part of the acute management, particularly if the stroke is confirmed. Transfusions help dilute sickled cells, reducing the proportion of sickle hemoglobin and improving cerebral perfusion. Anticoagulation: although not typically used in the acute phase of ischemic stroke in sickle cell patients, chronic anticoagulation may be indicated in certain cases if the patient has a history of frequent strokes. In the longer term, interventions to reduce the risk of future strokes include chronic blood transfusion therapy. This is recommended for patients with a history of stroke or those at high risk for strokes, as it helps prevent further cerebral vaso-occlusion. Hydroxyurea therapy: this drug increases fetal hemoglobin (HbF) levels, which helps reduce sickling of red blood cells and is often used for stroke prevention in sickle cell patients. Regular follow-up for ongoing management and monitoring of any new complications.